I'm really delighted to introduce to our audience Kylie Mills, who is a continuous improvement coach at Jones Radiology. Kylie and I have a common friend, colleague, Sue O'Neill, who spoke at our Lean Enterprise Australia Summit a couple of months ago and showed a couple of really fantastic A3s that demonstrated some of the work that had happened at Jones Radiology over the last couple of years. And it sparked my interest, and I thought it would be great to invite Kylie today to share with you and to share some of the learnings and the methodology that has been used while she's been the coach at Jones Radiology for, I think, about the last 3 years, 3.5 years.
Yep, just past my 3 years. Thanks,
okay,
Denise.
So I'm going to actually hand over to you to introduce yourself. I think you've got a few slides.
Yeah, great.
Yeah.
Just check that that's come through okay.
Yeah, we've got it.
Yeah, great. Yeah, so physiotherapist by trade, and started my lean journey in a large public hospital system in the southern Adelaide suburbs, and really worked across all clinical and non-clinical areas in the large public hospital. But again, followed a mentor and a great leader in lean over to Jones Radiology about 3 years ago. So we're a high quality medical imaging service. We have about 700 staff across 28 sites. So we service within metropolitan Adelaide, but also regional South Australia, and even one clinic up in the Northern Territory. So we're doctor owned and operated, which we're really proud of. And that's what sort of brought me into cross organisation, but we're still within healthcare for my lean journey.
Thanks, Kylie. And I wonder, as a clinician and someone who'd been doing improvement work in a large health service, the same health service that I probably earned my stripes a few years earlier. I wonder, what differences have you found in a corporate organisation across, multiple sites as a coach? How different has that been for you?
Yeah, I think, Denise, what's nice to start with is how similar it is. How similar the two systems are, in that it is all about the patient. It is all from their perspective. It's around making the work easier for our staff. And, that's always been our focus across both, is if we get that safety, quality, delivery, people domains and what we're delivering right, then the cost will work out itself. So it's certainly not had any change on my intent of what improvement looks like in public versus in private. I guess what's different, as you'd know, public healthcare is extremely well governed. There's very firm policy frameworks that we work within. It's large data systems that sometimes can be challenging to pull what you want when you need it and be agile with that. And really, I think what was different in public versus here is they did have a very embedded culture of continuous improvement, particularly at SAL. And so we weren't having to sort of introduce what we were talking about. We can just sort of launch in. There's a lot of history there. So really what's different as I've come across radiology is we're being smaller, we're much more agile. We can have better control over local change, which has just been such a catalyst for improvement success here. I think availability of data and being able to sort of just extract what we want and be really dynamic with that has really been a great basis for us. And I think of where I'm placed in the organisation now, and I could hop up, and within 10 steps, I can be at every executive level. I can be with people and culture. I can be with accounting. I can watch frontline staff in the contact centre. And I think that's what's so great about this smaller organisation and doing improvement is, while we're a team of two and mighty, but we're so close to everybody as well, which has been really great as well. In saying that, improvement has been new in this space, so we are having to start with really basic foundations. So standard work has been a real emphasis of our work, and visual management, just to start those foundations for greater improvements.
It's really it's a real privilege when you've been working in an organisation that's quite mature. It's a real privilege to be able to start again and think about what can we do differently, what can we try. And certainly sounds like you've had a lot of success there. So let's push on to to one of the A3s, and I've had a little time to digest these. So if we want to flick that, but for me, this is a lean practitioner's dream, this A3, and I spent a whole lot of time reading through it, asking questions. Can I see this? Can I not see this? What's been going on here? But my understanding is the two A3s that we're going to look at today are both around heart scans, heart tests, and the first one is a fairly high volume process. And my understanding is that your demand was outweighing your capacity, and that you had a demand issue. But actually, as you started to look, you found that the time on the scanner on the table was a lot less than the appointment template offered.
Yeah, absolutely,
and
Denise.
I suppose one of the things that we often in healthcare sort of sit back and scratch our head and think about is how did this happen? How do we end up with something that has just, I don't know whether it's evolved over time or but certainly doesn't have that design piece.
Yeah, absolutely. Yeah, so this was really one of our initial A3s in the organisation, and first time we've sort of put it onto an A3 to sort of have that frontline-led problem-solving approach. And I think the mission I was sort of given was it's a 45-minute scan on our template, but the sense is we could go a lot faster. We could potentially go 30 minutes. And I can't speak before I came, but historically, would that have been a directive? Possibly. But really, it was around that first time of looking at, well, what does the data tell us about our time on that scanner? What does the patient perspective look? So really looking at the whole lead time of the patient experience coming in for these examinations. And I think we've got very smart, very resourceful, capable people in our teams. However, we don't really look at these things analytically. And so I think that's been the strength of this role here, is to really map that out right from the beginning. How do we get first time quality of patients coming for these appointments all the way to the end scale? The machine is a part of that. And so what we're really unpacking is, looking at the data, we've looked at, yes, a patient hops on that scanner to have their scan, but how many steps came to the patient coming on the table, and how many steps follow afterwards? And really, how can we rearrange them or make them easier so that those happen in and outside of the room rather than on the scanner itself? And that was the key for this. So really using that 30 minutes of what the scanner is doing there, which is to acquire the image. So I think it was really around bringing all those content experts together and mapping out every step. And that was a very new concept here, to map the entire patient journey, and so many aha moments along the way. And it's not really, I think historically, sometimes our machines and the technology advances, but our processes probably don't change. And so we're suddenly a lot more efficient in our scan acquisitions, but our whole process end to end can't keep up with that sort of improvements we've had in the actual scanner. So we used the scatter plot you can see on the A3, and this was one of the early ones that was a little bit of hard work to get from the data team, but now it's just so easy, 2 years later, and I can pull that within 5 minutes on Power BI, which is incredible. But really looking at looking at the data of how long did that take for us to get the image from an 80-20 rule. And that's a new concept. So let's not redesign the whole template appointment around the slower patient, the more complex heart rate control. Let's design it around the majority, not the minority. And the scatter plot gave confidence to the team to see, I can see that we could easily bring that 45 minutes down to 30. So I think that's sort of where we ended up with this problem to begin with.
A scatter plot can be really powerful, I think, and I love your use of it here, because I'm assuming that red line is the template time, the 40.
Absolutely.
Going across the scatter plot. And every one of those, I like the way in the scatter plot they're round circles, because to me every one of those is a patient face.
Absolutely.
And you know how long that they're staying there, and you think, well, there's real opportunity here in terms of redesigning the work. We're going to flick through to another slide, but also the swim lane map here. As I was sort of looking from your current state to your future state, and I like the way that you've shown it. It looks to me like you've done a lot of rearranging of the steps rather than sort of eliminating steps.
Yeah,
There seems to be
Denise.
a lot of rearranging of the work so that it flows better.
Yeah, definitely. So I think we really pose the question of not removing steps, because again, most of the steps put in our process have been well thought out in isolation, perhaps, so they've all been put in, and historically we then have this sort of build of processes that all add value. But what we really asked is, how can we do these differently? How can we rearrange them? When's the right time, but when's the right person? Where should this happen, as opposed to actually eliminating? So this is probably one, like you said, that didn't eliminate a lot of steps, but really thought about the scanner as being the integral time critical spot, and what steps can we do before we get in there, and then what steps can we do after we get in there to make that more useful. So I think that's where it's been really helpful. We've used a lot of the downtime acronym here to really look at waste differently. So waste is a new word we're using here, and waste is not a staff member sitting idly on a computer screen or waiting for the next patient, but starting to see that waste was actually, an example was we would fill out a consent form from a patient, or sort of pre-screening, and it would be 2 pages. So we would take time every patient to scan both pages in, and sort of, there was error in that, but also that took time. So the small incremental changes of little things like that can make a big difference, just by sort of reducing, eliminating, combining those steps.
And the results from this value stream improvement have been, very significant. And if we just flick back to that A3, I think that we can see those there in box number 7. So, absolutely better for the patient. Their time in the imaging services looks like it's about 33% less, and this enormous benefit from a utilization point of view, which has got to be good for the organisation. And I know, working with surgeons, and I imagine that working with radiologists is the same. They just, like, surgeons just want to operate. And so I'm sure from a, radiologist point of view, there's, they just want to be using that scanner, and, they just want to be maximizing the value add that they get from the technology that they have.
Yeah, absolutely. Yeah. So I think that's where you can really see that time on the scanner of the actual appointment, was reduced by 50%. So, we were using 50% of that appointment time on the value adding scan acquisition. Our actual scanner time change didn't change between the intervention, because we weren't asking people to scan faster. The machine suddenly didn't scan faster, and we still have, we still have to get that heart rate control right and things like that. But what we really saw was that utilization. So same resources, same hours, but instead of sort of 3 or 4 of these scans sporadically through the day, where we'd have to have booking agents coordinate up to 4 different resources to sort of get the right outcome, just using sort of block booking and scheduling just meant we could really use the same resources to sort of get the dual processing happening, which saw great outcomes in that activity uptick. So, we were a 21% uptick at the pilot site before we went across organisation-wide, and saw a 23% increase in these, not necessarily from more demand. So it's been a great outcome, definitely. And I think the patient feedback we got is sort of, when we first looked at that, of course, we go straight to the patients and talk to them about their experience. And it was the experience of waiting for the next step, on the table, sort of arms ready and ready to have that scan, and the anxiety lying there. But then we'd have to go and get another step done and another step done. So, we've certainly made the patient experience much better, which is ultimately why we do all this work.
Fantastic. We might move to the second A3. And I love this one because we usually start with lean. We encourage, as coaches, we encourage our teams to think about high volume work, because high volume work usually responds really well to lean tools and techniques. And what I like about this one is that, you've actually attacked what we call a red stream, something that's lower volume, high in complexity, but also, you know, high in pain points for your team members. And, you know, really, I think when we had our preparation conversation, you talked a little bit about, you know, the equity side of this is that you had a whole group of patients here that weren't getting their test done. And waiting, I think it was up to sort of 120 days and an ever increasing backlog. So I'd love you to share a little bit of the work you've done here.
Yeah, definitely, Denise. So these are patients who require MRI for any other reason a patient would require MRI, but because they have a metal implant in their body, have to go through sort of an additional step. So we treated these patients as quite complex because of the safety processes we'd have to put in place, third-party arrangement and the scanning. However, what it really was it was just complicated, and the way we were doing it was complicated. So trying to reframe these patients, whilst they're a minority, these patients only make up about 1% of our MRI patients we scan every week here at Jones, but they were waiting up to 120 days, and their counterparts were sort of only waiting that 40 days for the same scan, potentially from the same referrer. So we were getting great feedback from key referrers, from patients, from staff in the processes themselves. They're the ones who've raised this as well, to sort of say, you know, yes, it's a small group, but gosh, we can do things better for this because, you know, equity isn't necessarily about volume, it's about patient access for all, it's been such an incredible program, this one.
So because of the complexity and the volume, did it mean your approach needed to be different in terms of progressing the work in this value stream?
Probably a little bit easier to make everything really visible for this. So because we were talking about a very niche group, it was a lot easier to really process map this and understand what that looked like. When we first started, we sort of wouldn't have known how many of these patients we get referred per week. We know that we would see 6 patients per week per vendor. So we'd have up to 3 or 4 vendors give us 6 appointments a month. And so we would just sort of take those 6 that came through and pop them in. And that's where we had significant wait time for these patients to be seen. We hadn't, again, historically sort of challenged that we might need more because we didn't know our data well enough. So I think what was key about this is because it was a small group, we could really pull that data and have a look. Well, actually, we give equitable lists for each vendor, but our demand is actually mainly 2 vendors, and they're the ones that waste as well. So I think we really looked at it that having a patient-led template and cadence has just been such a priority in this space.
Fantastic. And you know, my eyes are drawn to so many things on this A3, but I can see the value stream map here. And, you know, often in healthcare, we struggle with value stream maps. And I wonder if you'd like to share a little bit about what you learned from that value stream map and the help it provided in terms of improving your outcomes.
Yeah, absolutely. I think this was a really great piece in how many steps and to get the milestones into the value stream map of what that looked like. Because this was third party dependent, we had dependencies for third party. And so when you first come together and you're sharing your frustrations with the process, we would hear, oh, well, this is sitting with cardiologists or this sits with those vendors. And until we could really put it in that value stream map and put data against each milestone, but also look at what's within our control. So where was our rework that was happening downstream or errors from downstream because we didn't get first time quality at the very first step, was probably the most insightful work for us. What we also really saw in the value stream map is if we were to just turn on the extra capability in the machine. So, you know, if we were to say, well, we can make it work because like I said, we're very agile. We can move our templates how we like to, and we can say, we'd like to turn on some extra capacity for these patients. We're going to ask the vendors for extra lists. What we really saw with this is our real bottleneck was in the clerical processing. So, you know, a very strained workforce that was, when we were able to staff it, really only able to manage sort of inbox traffic and sort of that real push approach of I'll just get today's work. And so the growing backlog was quite comprehensive. So we couldn't turn on the machine until we had really streamlined clerical processes. And that's sort of where that map helped us sort of see where our bottlenecks were.
How did you engage the clerical staff?
Oh, this was a success story. This was excellent. I think you really, we make it really clear that this isn't done to people, that improvement is done with the people in the process. But we also acknowledge that this is always on top of their BAU. And I think that's probably the struggle we find so much as coaches is this is extra. And you know, the improvement curve, they have to put extra in early before they're going to ever see those results. And so it's that steep curve initially. Here we've been able to have some great resource to be able to support. You know, we had a practitioner, improvement practitioner in this space to actually help us understand that process and have expert input in redesigning it so that it still felt fully owned by that team, but also had some help to be able to see the gains that we've made because, you know, there was a lot of work behind the scenes in streamlining those processes.
And the target you put in looks really aggressive, you know, like going from going within 3 months to go from the 120 days down to, 2 weeks. Why were you so aggressive with the target? And what was the main thing that you did that helped you achieve that target? Because you actually surpassed the target by
We
the
did. The target
result.
kept moving, Denise. And it was actually the people in the process that said, I think we could be more aggressive than that. You know, I think what we really looked at and when we did the value stream map and the individual process steps is what would good look like if we could realign all of our steps and do all of the what we can do then to third party. What would be our ideal, what would good look like? And I think we had a really easy benchmark that what we were trying to achieve was equity. So if we could say that our target to start with is to have the same access to that appointment as a non-pacemaker patient, that was our ultimate goal. That was the equity. But we just kept getting more and more streamlined with this and really started to see that surpassed. And at times they can be seen far earlier than a non-pacemaker patient. But that's the balance that we keep making. You know, we just want that equitable care across all groups.
And I think that run chart in your safety processing pipeline demonstrates the backlog and what's happened with the backlog over the period. And I'm sure that you're progressing that into a continuous improvement piece as well.
Oh, absolutely. Absolutely. And there's monitoring of that run chart now. The visual management around this is it really leads the work and the BAU. We make sure the work is visible all the time, which is really good. And I think one of the key things that we really saw there is, like I said, there was early commentary that perhaps it was sitting with cardiologists too much. But, you know, when we actually met with a couple of key cardiologists, we realized that actually we're sending them 4 to 5 different types of checklists. They don't know which one is which. They'd have to print them off, they'd have to fill them out, they'd have to scan them back in and then email them back. We were making it so hard for them. So, you know, with some great third-party involvement and consultation and with the vendors, which were brilliant, we've come with a vendor neutral checklist that now goes to our cardiologists so that the only one they get is the one we've co-designed. It's editable, it's PDF, so it's just the process is so much easier. And I think the other thing we really worked hard on is that tacit information. We know that, at that cardiologist clinic, they like us to go to the heart nurse, or they like us to go to the PA, or that cardiologist likes that email direct. And so just building a really simple matrix behind the scenes of that tacit information to make standard work a lot more predictable and be really targeted with who we ask, when we ask, and how we ask for that information back made a big difference.
Great conversation, and because I didn't get us started early enough in the session, we lost a few minutes. But I just it's really evident that you can see in this work you've made things better for patients, you've made things better for staff, you've made things better for the organisation. I just wonder in the last minute whether you could just share with us if you went back into a major health service now after what you've learned in the last few years, how might that affect your approach in terms of working with areas like radiology?
Yeah, absolutely. I do remember when I was about to leave the public healthcare system, we did start a project that was going to be in radiology, and I just I think if I know what I know now, my whole approach would change. So it's a bit like with the vendors and the cardiologists with this pacemaker project. Is third party doesn't have to be challenging. So they're with great collaboration and understanding for a shared goal, I think we can get such more positive outcomes. Yes, it's harder work. Third parties, they have different governance and policy systems than we do. But bringing people together to see that map end to end, I sort of remember that I saw radiology as a step in the patient journey, when I was mapping the big picture in the public healthcare. Well, now I know radiology has that many steps in itself here. So, imagine what that insight would help my colleagues and things when we are mapping that whole patient journey, because there are bottlenecks everywhere, systems that don't integrate and communicate together, but how can we come together? So I think just taking that back to really connect the two would be fun.
Fantastic, Kylie. Thanks for joining today. Thanks for presenting. The A3s are fabulous, and it's really great to learn about what lean-based improvement looks like in a radiology practice. We could talk for another half an hour, but unfortunately we need to move on to the next session. So thank you again, and goodbye.
Thanks for having me, Denise. See ya.